Welcome to A Real Affliction, BPD, Culture, and Stigma, a podcast devoted to exploring how we experience, treat, write about, advocate for, and conceptualize borderline personality disorder. My name is Cynthia Gralla. I'm a writer and teacher with a history of BPD. Trigger warning, this episode will mention suicide. What follows is the second half of my interview with Dr. Sara Masland, a clinical scientist who writes about BPD and stigma, a licensed clinical psychologist, an associate professor of psychological science at Pomona College, and an expert in good psychiatric management, a generalist treatment for BPD. In the second and final part of my interview with her, she and I will contemplate the prognosis for people with the disorder and the connection between BPD and menopause. We'll also deliberate whether a writer should purge the darker parts of her BPD story and what needs to change in medical culture over the next 5 to 10 years. In addition, we talk about prevalence and gender distribution for BPD. Today, one of the pressing issues is caring for trans and non-binary people with the disorder with sensitivity and respect. For many years, most of the people with BPD who were studied by researchers were cisgender women because they were diagnosed with the disorder far more frequently than anyone else. Optimistically, Dr. Masland points to recent articles that turn attention to trans and non-binary people. One article from November 2023 looks at gender and sexuality-minorized adolescents in dialectical behavior therapy. It postulates that given BPD's likelihood to blossom in people invalidated during childhood, increased exposure to a socially oppressive environment, which likely communicates and encourages the internalization that gender and sexuality minoritized identities and experiences are invalid, may result in a higher prevalence of BPD among this community. Dr. Masland also notes that one of the criteria for BPD, identity disturbance, poses a problem when dealing with this cohort, as it may lead clinicians to pathologize what can be a healthy questioning of gender and identity. Yet the future of all of us with BPD is not as dark as the past. In this episode, Dr. Masland and I reference the McLean study of adult development, one of the first longitudinal studies to chart the life course of BPD. Its psychological map reveals that most people do recover from the disorder. Dr. Masland and her co-authors wrote, "A major contribution of this study is the report of frequent and sometimes stable remission and recovery from BPD over time. The McLean study of adult development defined remission as no longer meeting criteria for BPD during a 2-year follow-up period. It defined good recovery as a 2-year remission of symptoms with at least one emotionally sustaining relationship with a friend or life partner and the ability to go to work or school consistently, competently, and full-time. Remission and recovery from BPD were common, though not necessarily stable. At a 20-year follow-up in the study, 59% of participants had met criteria for a good recovery, and 39% had met criteria for an excellent recovery, which is described as a remission from symptoms, at least one sustaining relationship, the ability to go to school or work full time, and the absence of any functionally impairing Axis 1 disorder, such as depression. I hope that everyone listening who has BPD will see the storm clear. Do you think the disease is becoming more common, or is it just that people are recognizing what it is? I'm always a little confused about incidence versus prevalence and lifetime prevalence. So maybe explaining what the prevalence is and whether you think it is rising.
So the prevalence, I think the best prevalence estimates we have are between 1% and 2%. If you look at the research on prevalence, I think there's one outlying study that says something like 6%.
There is, and that threw me. Yeah.
Yeah, I think that there's reasons to maybe not hang your hat on that estimate,
right.
actually.
Yeah.
Just methodological issues with that study, actually.
Right.
If you kind of do a reanalysis of those data with kind of more accepted methodological approach, it comes back down to that 1 to 2%. So I would think about it in the range of 1 to 2%. I don't know that there's any evidence that it's becoming more prevalent. I do know, however, that we're, gaining more knowledge about it, and that might affect diagnostic rates, right? While at the same time not affecting kind of true prevalence. And I think that we're also starting to think about personality disorders in a more dimensional way, with the understanding, right, that there are lots of people who might not meet those very strict categorical diagnostic criteria, 5 out of 9 symptoms in the DSM. But there's many people with, example, 4 out of 9 symptoms, 3 out of 9 symptoms who would benefit from treatment. And I think we're starting to do a better job of understanding that through new dimensional models of personality disorder, understanding just that kind of natural variability.
And you also have written that you see BPD as being equally prevalent in men and women, but or I don't know if that's the exact way you formulate it. And yet 75% roughly of the people who are diagnosed with it are women. So why is that? Why is that discrepancy between possibly the reality and who gets diagnosed?
That's a great question. And there are a few sources of the discrepancy. One is clinician bias. So clinicians might have their own biases that lead them to see men or women more easily through this lens of BPD.
Right.
And we could think about all the sources of those biases. There could be kind of criterion bias. So it could be that the criteria themselves are written in a way that kind of picks up on the difficulties that men versus women have, right? Or the way that they would express BPD. And I think those are probably the two primary sources of bias. But then we also have issues of kind of treatment seeking and just kind of societal norms around whether it's which types of problems it's acceptable to seek treatment for, and how we talk about those problems when we actually get into the clinician's office, and that might affect the actual diagnosis. So it's probably a culmination of all of those different biases. For example, I think that there's a way that it's more or less acceptable for men and women to express certain types of emotions, right? I think that we often see anger as less acceptable in women. And therefore, we might be more likely to say, oh, this person has an anger problem because that's less acceptable in a woman. Whereas we might tolerate anger from a man to a much greater extent without calling that a symptom of a disorder. So that's one example of how bias might factor in.
Yeah, absolutely. I can see that. Is there any research about diagnostic rates for trans people, non-binary people? Is there any insight into that?
So there's actually a few new studies on this just in the past few years. I think it's really fantastic that folks are considering this. There's a researcher, I believe he's at the University of Minnesota, Craig Rodriguez-Seijas. I don't know how to pronounce his last name actually, but it's Seijas. And he's done some fantastic work on this recently. And it's really important because if you look at the criteria for BPD, there's actually the possibility that those criteria could be used in a way that would misunderstand trans or queer experience. Because one of the criteria is difficulties with, identity disturbance. Right. So having difficulty understanding who you are in fundamental ways.
And pathologizing that. Yeah.
Yeah. And we could absolutely, if we're kind of not careful with that criterion, end up pathologizing. I think about an adolescent who's having kind of what I would consider normal kind of questioning of gender and sexuality. And if we pathologize that would be a big problem. We should be helping that adolescent explore that. At the same time, we need to make space for understanding when identity questioning or identity disturbance is kind of at that threshold of being something that we would be concerned about. So, that's one criterion where I think we need to very carefully kind of map out how we should be applying that so that we're not pathologizing trans and queer folks.
Yeah, absolutely. And I know historically, most of the people being studied have been cisgender women, the bulk of them, because they were the ones getting the diagnosis. So it's great that there is research coming out to help other people as well. It's interesting because studies like the CLEAN study, or the study of adult development, offer such a hopeful trajectory of the disorder overall, but it has such a reputation of being difficult to treat, or it seems like a lot of people don't know that it's something that you can overcome. I've even seen in BPD subreddits people pushing back against someone who says, well, I no longer meet the criteria. And they'll say, well, that's not possible. Why do you think there is this lingering sense that BPD is something that you can't overcome over time?
Mm-hmm. That's a good question. I have a few ideas about it. One is that I think when clinicians do not have the tools to help someone, it
Mhm.
can be easier to blame that person than to reflect that you don't have the proper training to help that person.
Right.
And so I think sometimes clinicians who are, you know, very well meaning in many ways will say things to patients that don't reflect an understanding of the broader landscape because
Right.
they themselves don't have those tools to help. And this, you know, I go back to the importance of education and
Right.
increasing their
Yeah.
understanding. I think we need to be doing more to make sure that all clinicians have tools to help people with BPD. John Gunderson used to say this beautiful thing where he would just say, any person with BPD deserves to have a clinician who knows how to help them, right? Full
Mhm.
stop, right?
Yeah.
Until we get to that point, we're not done. We
Right.
need to be getting that training out to a
Mhm.
greater extent.
Yeah.
So I think that's one factor. I think another is that if you look at the longitudinal data, you know, there are many cases where, for example, we see that symptoms remit, but there are some people who continue to have kind of functional difficulties,
Right.
even in the face of symptom remission.
Mhm.
And I think that we need to do a better job of understanding why that is the case. And I think
Yeah.
sometimes that might be the case because if you are struggling enough isn't the word, but if you have significant struggles during formative periods of your life, even when your symptoms get better, you might be left in a place where you don't have kind of the social supports or the
Right.
kind of values guided kinds of activities in your life that you would like to
Right.
have.
Yeah.
And I think that, you know, this is also a focus of GPM is, and DBT says, you know, you need to build a life worth living.
Yeah.
GPM has this focus on, you know, finding work and meaningful
Yeah. I
activities.
like
And
that.
I
Yeah.
think that, you know, we have this understanding that we actually do need to be focusing on that more so that when symptoms remit,
Mhm.
people have a life, right, that is
Right.
worth living and that they can function in
Mhm.
the way that is meaningful to them. So
Yeah.
I think there's maybe a misunderstanding of like that split between symptom remission and kind of functional recovery.
Right.
And I think over time, I'm hopeful that all of the stories that are coming out about recovery will help shift this narrative. There are
Yeah.
lots of organizations, I think, now focusing on this idea of recovery in a
Right.
way that hopefully will be healing and will help with this.
I have a follow-up question about this long-term trajectory, which is there any research about the interactions of BPD and menopause? Because I definitely felt that I was in a really good place. Around age 40 was where it took a long time for things to kind of
Mm-hmm.
calm down. And I was in a stable marriage. I started teaching. I felt that I didn't meet the criteria at that point and was pretty happy. And then a couple of years ago, when I entered perimenopause, it took me a while to figure out that's what was happening. It was awful. Emotionally, I felt kind of thrown back into really unstable moods and even
Mm-hmm.
some suicidality. And the insomnia didn't help, and all these things that eventually I went on HRT to sort of get under control and went back to
Mm-hmm.
therapy. And I tried looking up what had been studied on this, and I couldn't really find anything. I have noticed on forums, both for BPD and menopause, people asking, "Hey, is there anyone else out there who has BPD and is going through menopause? Because I'm having a really tough time." And of course, the good news is that even if that's true, it should calm down after that period's over. But I was just wondering if there is anything out there about that.
So I 100% agree that this is an area that deserves significant attention. There's every reason to believe that hormonal fluctuations, particularly those seen during menopause, would lead to symptom exacerbation for BPD and for a range of other, difficulties. We know, for example, there's a second uptick in psychosis at the period of menopause, irrespective of BPD even. So absolutely, this is something that's needed. I think we're not there yet in having a full understanding and in thinking about what should the treatment intervention be at that point. It's fantastic that you were able to kind of monitor that, right, in yourself and get access to HRT. My guess is that we have data on it, maybe that aren't published though, because I know someone at Brown University, Jessica Peters, who's doing work that I would almost guarantee that she has the data or she's working on this, even if it's not published yet, because she has been asking these questions about hormones and she's someone who's interested in BPD.
It's a bit of an axe I have to grind just because I think it would be really good for people to have a heads up that that might happen. And I should have figured that out. Just having that kind of this hormonal shift could be really difficult for people who already have a penchant for mood dysregulation, even if they've gone through treatment. So just when you know what's happening, then, or if you expect it, I think it could be an easier transition. So yeah, and I was very fortunate. I have a wonderful gynecologist who listened to me. I said, I think the risk for me of suicidality and depression outweighs any risk for the HRT. And I didn't have a history of breast cancer in my family. So I was really lucky that, I know some people get pushback from their gynecologist. So that was what I suspected. So I just wanted to make sure I was right and that I hadn't missed something. But
absolutely.
I just have a couple of more questions. One is, what role does sharing lived experience with BPD play in all kinds of things, in decreasing stigma, hopefully, or just increasing understanding about the disorder? We are getting a lot of people writing and podcasting about it. As I explained in my first episode, there are a lot of good BPD podcasts out there. I was looking for one that was more of an interview format, so I started mine, but so many people are talking about it. Does that help, even if they're sharing some of the very dark times they had? I do worry about that because I couldn't access treatment for a long time. I had one of those therapists who said, oh no, you don't want that diagnosis. We'll just keep pretending. This is depression. This is anxiety. Take your medications. And the medications were not good for me. Some people, they need things because there are often comorbidities, I know, with depression, but I just was on way too many. So there were dark times. And even when I write about them, I clarified, this is me not getting the proper treatment or acknowledging myself, being completely honest that this is what I have, because I didn't want the stigma. I was already so down on myself. So I worry, is there a limit to what you should share, or is it really good to have lived experience that's honest?
It's a great question.
I'm not asking you to tell me what to write, but
of course.
I'm just curious on your perspective.
Of course. So if we look at the basic stigma research done by Patrick Corrigan and others that comes out of social psychology, we see that there's kind of three main ways to intervene on stigma. One is education, and I'm a big proponent of that. Yeah. Another is protest. And the third is contact. And all of the research seems to support that contact interventions are the most effective. And contact interventions are those in which someone comes to know someone with the diagnosis, right? So there's a humanizing aspect where it's not just this diagnosis that's understood out of human context. Here's a person, a full person, right, who has had this experience. And because we know contact interventions are the most effective, I'm always a huge fan of people coming forward with their stories. I think that it does humanize. And I think that the more stories we get, the more people can actually start to see the variability in experience as well, which is important. And I do hear you that maybe there's this concern about, sharing those darkest times. Can that increase stigma? And stigma is a very slippery, difficult thing. And I think about these issues all the time. I don't know that we can be sure, actually, but I also know that sugarcoating any kind of experience or shying away from those dark parts, I think can actually make stigma interventions feel less credible. But I also think that there's a way that they can actually entrench stigma in its own way. Oh, this is too dark to even talk about. This is something that we shouldn't even look at, right? Or that it's not okay to speak about. I think there's a way that when we take that perspective to things, it can actually increase stigma. And also, I think that there's something much better about saying, yes, let's fully understand what the whole experience is, knowing that we can handle it. This is something that we can look at and we can understand, right? And we can incorporate this into our view of this full human person in front of us.
No, I absolutely agree with that. It's one of the reasons I've enjoyed doing research into some diaries that were written by women with BPD, or at least BPD traits in one case. And I'll be sharing some excerpts of those in a future episode. But in a diary, you get to see the full spectrum. You get to see these women feeling terrible and fighting for their lives. But you also get to see these joyful, loving people who, in the diaries I've read, both of them that were posthumously published, they're so concerned about others. They're worried about others' feelings. They're trying to take care of their family members as best as they can, their friends, their partners. They're praying for people. They're praying for other mentally ill people. And you really get a full picture of just an incredible human being who was saddled with so many emotions and challenges. And I find it inspiring. But like you said, stigma is this slippery thing. But I appreciate your perspective for sure. My final question is just what your hope is in terms of treatment, research, and conceptualization of BPD over the next 5 to 10 years.
So my number one hope is that we can continue to make treatment more accessible. And I think that will best be achieved through generalist approaches and not just good psychiatric management. There are other generalist approaches as well.
Right.
I think that we need to be making sure that people have access to care that's going to be helpful for them. I think every person with BPD deserves that. It's a fundamental right, I would say. I'd go as far to say that. That's one hope. I think another is that by disseminating some of these generalist treatments, we can start to make some traction on the clinician stigma piece. This is something where I've been thinking a lot about this and hoping in my own research to start to tackle this issue of, we know this clinician stigma exists, and I think we have a good sense maybe of why it exists in many ways. And often it boils down to lack of good educational experiences and clinical experiences, during training. And I think we need to make traction there. I hope that we can do that in the next 5 to 10 years. I think that will have cascading effects on stigma, on access to care, on everything. I think that would be really important. And then my third hope is that we do see this trend in integration and collaboration continue. I hope that, the DBT folks and the MBT folks and the GPM folks, I hope that they are all talking more together. And I hope that they're thinking about how they can work together to improve the landscape of care rather than kind of operating in their own kind of theoretical silos.
I've heard this desire for increased access to treatment from a few different people. So I think that's a really common theme. And I think all of these things are really important. My hope, too, is that as we see interdisciplinarity becoming more common in academia, at least it seems to be, just this acknowledgement that for complex problems, we have to work together and across disciplines. Maybe that trend will also kind of affect the siloing within just one focus of research or discipline. So I'm hopeful about that. Thank you so much for talking with me today. It's such a great perspective. I think for me, it's really hopeful to hear that people are really responding through their research to the need for more care for people with BPD. Is there anything final you would like to say?
I would just like to echo a sentiment that I put in the paper that I think you first read of mine, which is that despite all of the stigma about people with BPD, folks with BPD I've worked with and that I know personally are some of the brightest lights in my life. And they deserve podcasts like this. They deserve attention to these issues. And I want to thank you for sharing your own story and for making this content, and for inviting me to be a part of it. I really appreciate that.
You're very welcome. Thank you so much, Sara. And just keep doing what you're doing for us. Thank you so much.
Of course.
I'd like to thank Sara Masland for generously participating in this interview. Please come back on July 15th for the first part of my conversation with American McGee, the video game designer and mastermind behind the Mental Health Plushy Dreadfuls line. Have a great day. Thank you for listening.